Hey everybody, thanks for tuning in. I want to talk today a little bit about, I was at Academy in New Orleans recently, and I was asked to provide a summary of what's the latest from Academy in terms of ocular surface disease, what's going on, what's new. There's certainly a lot to be said about what's happening. There are new drugs in the pipeline that could be coming out very soon. There's a new business model from Tier Science that can provide a treatment for MGD, which we see all day, every day, to our patients and make that more affordable. There's a lot of stuff that's going on. And if you think back to 15 years ago, 10 or 15 years ago, Restasis may have been brand new or didn't even come out yet. We really had artificial tears. We had punctal plugs. We didn't have a lot. We had Schirmer to test for dry eye. We could look at staining. Now we've got new tools in terms of how to diagnose and treat. We've got Inflammadry. We've got Tear Lab for osmolarity. We've got new lid wipes aimed at treating blepharitis with tea tree oil. So there's a lot of new treatments. There's a lot of new ways to diagnose dry eye. But I'll tell you, my biggest takeaway from Academy was a poster presented by Justin Kwan. What he looked at was prevalence of ocular surface disease on a group of consecutive patients. The average age was 43 years old. And they looked for posterior blepharitis or MGD, they looked for dry eye, and they looked for allergy. And of all these patients, there were 256 patients, only 27% were normal. Now, they didn't even look at anterior blepharitis. So we're really looking at a huge percentage of our patient population that presents with some sort of disease. And I think, to me, the biggest thing is we're not still finding enough and treating enough. It's still a very, very underdiagnosed and undertreated set of conditions. We really, as a profession, should be taking this more seriously. It's a big opportunity for us to provide a higher level of care to enhance our patients' lives through better vision, eyes that look better, eyes that feel better, eyes that see better. And more, we're seeing patients, aesthetics is working its way into our profession, and patients want their eyes to look whiter and brighter. They want them to look better. And we should be paying attention to that. If you think of disease states, and I compare this to a dental model all the time, if I go to the dentist and he tells me I have a cavity, the dentist could really care less if I'm complaining about this. He'll check for pain, I'm certain, and sensitivity, but if he tells me, you know what, you've got an early cavity, come on, I want you back next week and we're going to fill it, what do? I go back and I get it filled. The reason I do that, I go to my dentist. Why do I go to my dentist? I want a lifetime of healthy teeth. And I assume that's why my patients come to me. They want a lifetime of clear, healthy, comfortable vision. So if I see a disease state sitting in front of me right in my practice, I'm going to mention it to the patient. I'm going to tell them, I'm going to make my best recommendations. Whether or not they're really complaining, I'm going to make it clear you have a disease that we can treat. This is chronic, it's progressive. If we wait to treat it, it's going to get worse. So I really think it's important that it's not so much what's new. What's new, everybody has ocular surface disease. At least in this study, 73% of our patients have some form of ocular surface disease. And again, that was not including anterior blepharitis. So we really need to be asking ourselves, are we finding this? Are we treating it? Are we ignoring it? Do we think it's not significant enough, not important enough? I really think at this point what's going on with ACOs and HEDIS scores, what's going on with vision plans, we really need to provide the highest level of care. This is a great way to do it. I really think we've got to all just recognize we have so much room to grow in this area, and it is, when we talk about owning a disease state, for example, in our profession, I truly believe, don't forget, vision begins at the tear film. It all depends on the ocular surface. The retina can be as healthy as possible. If you have an ocular surface that stains with fluorescein, or the tear film is unstable or inadequate, patients aren't going to appreciate the kind of vision that we really want them to have. Start thinking of ocular surface disease as a vision disease. We're vision doctors, we're eye doctors. We want to provide the best vision possible. It starts at the tear film. Don't ignore it. Next time you see 10 patients in a day, ask yourself if you found 7 cases of ocular surface disease, because that's probably about average. Anyway, thanks for tuning in. Good luck. Bye-bye.